We're going to continue our journey today into the shoulder complex by examining the glenohumeral joint mechanics. This is that component of the shoulder complex that people think of in terms of, oh, it might hurt my shoulder joint. But it's only one part of an integral component, an integral complex, a linkage that allows normal upper extremity function to occur. But developing a good understanding of both the static and the dynamic stabilizers, the accessory motions that occur with normal motion, is necessary for understanding the deeply complex arrangement that the glenohumeral joint has, the scapulothoracic joint has, the sternoclavicular joint has, the acromioclavicular joint has, all on your ability to get your hand over your head and do the things that you like to do. Throw a ball, hug a loved one, eat, have a drink. All those things are necessary when normal mechanics drive motion. So when I look at the glenohumeral joint, it's a ball and socket joint with 3 degrees of freedom. The glenoid fossa is oriented slightly anterior and slightly superior. And that's an important concept, and we'll visit that in a minute in terms of stability. Now, it is longer than it is wide, and it's enhanced by the glenoid labrum. So we have a cartilaginous labrum that surrounds the joint, where the long head of the biceps tendon traverses through that labrum to attach to the supraglenoid tubercle. When I look at the humeral side, the humeral head is actually larger than the glenoid fossa, and the head faces medial, superior, and slightly posterior. So I have a normal angle of inclination between 130 and 150 degrees, with a normal angle of retrotorsion of approximately 30 degrees. So let's take a look at the ligaments that are primarily responsible for providing static support. So in this view, we can see the upward orientation of the glenoid fossa. So it's inclined slightly upward. So if I take and were to draw a straight line down from the supraglenoid tubercle, we would see that we've got a shelf that is created. And as we explore static stability, we'll understand the value that shelf provides for glenohumeral stability. But before I go there, let's talk a little bit about general stability, and we have to really begin first with the capsular ligaments. So when I add the capsule back to the glenohumeral joint, we can see that I have this nice broad range capsule that surrounds the whole joint. And we can separate the capsular ligament into a superior, a middle, and an inferior glenohumeral ligament. So it's kind of really a nice thickened aspect of the capsule. So that's the primary supporting structure that provides that glenohumeral stability. And I'll see people that will have chronic instability, that have either dislocated or subluxed their shoulders. And the typical direction for a glenohumeral dislocation or a glenohumeral subluxation is anterior. And then typically what it'll do is it'll come out anterior and fall inferior. That's the typical direction. Now, I know the question that you have in your head right now then is why doesn't it go out backwards? Well, again, remember that the orientation of the glenoid fossa is slightly anterior. So I'm going to eliminate that capsule again for a minute. I'm going to see if we can spin around here and take a look at, and hide some of this other stuff. And there's the glenoid fossa again. And again, if I take an anterior to posterior line, we can see again that fossa is oriented anterior, and we can really visualize well in this view the size of the humeral head in relation to the glenoid fossa. And when we talk about joint mechanics in a minute, we'll understand the importance of accessory motion with this joint. But again, with that orientation slightly anterior of the glenoid fossa, posterior stability is enhanced by the bony block. So same kind of concept. You know, I have a bony shelf posterior that provides stability, as I do when I look from a inferior view, that inferior stability that's provided by that bony shelf. So posterior and inferior in a normal position scapula will provide bony stability in relation to the ligamentous attachments providing a normal glenohumeral articulation. Which brings me to this next ligament that I want to take a look at, and that is this coracohumeral ligament. Now, the coracohumeral ligament runs from the coracoid process to the greater tubercle. And if I look at this ligament as a supporting ligament, the way that it functions is kind of cool, because what it does is, again, as long as the scapula is in an appropriately seated position. So I have that slightly upward oriented, superiorly oriented glenoid fossa. Imagine that this is the slope of a hill, and the ball then is going to want to roll down the hill. What keeps the ball from rolling down the hill is this ligament blocking that rolling direction. So as long as the orientation is upward, this ligament will provide a block to that direction of roll. The problem that we run into from an instability perspective is if all of a sudden I lose that upward position, now I have gravity pulling the humeral head straight down. That ligament is not going to check that motion. So static stability in the glenohumeral joint is dependent upon a normal position scapula. And if that scapula falls anterior and inferior or slightly downwardly rotated, then we lose stability. We lose static stability. And you'll see people that have had a stroke, for example, and lose normal tone in their upper extremity and their scapular stabilizers. And that scapula then falls into a downwardly rotated position. Over time, the weight of their arm, without that support, will start to lengthen the glenohumeral ligaments as well as the coracohumeral ligament, and those individuals develop chronic instability and chronic dislocations, subluxations and dislocations in the glenohumeral joint. So it's not uncommon to see a very positive sag sign, which is the space that goes between the humerus and the acromion process, widens when these individuals have that chronic instability. So a couple of other ligaments that are important in terms of positioning. The corticoclavicular ligament is actually two portions, the trapezoid portion and the conoid portion, and we'll look at the important role that they play when we visit scapulohumeral mechanics, when we look at the scapula in greater detail, as we do when we look at the sternoclavicular ligament. We're going to visit this sternoclavicular joint in a minute. And then lastly, we need to examine the acromioclavicular ligament, which provides that stability for the acromion and the clavicle, and we'll examine that in detail when we start looking closer at the scapula and next time. And then we have this last ligament, which really is kind of an interesting ligament. It goes from the coracoid process to the acromion process, and it's called the coracoacromial ligament. And it's really attaching one process of the scapula to another process of the scapula. So it's attaching scapula to scapula. But what it does also do is it provides stability. It provides part of this coracoacromial arch that is created. And that arch is what separates the humeral head and contains within the arch the supraspinatus tendon, the infraspinatus tendon, subscapularis, so the subdeltoid bursa. It provides space for those accessory structures. So again, with the glenohumeral joint being a triplanar joint, ball and socket, allowing motion to occur in all three planes, we can examine the motions that are responsible and the accessory motions. But before we look at the accessory motions, I want to take a look at just the gross physiological motions. So when I look at shoulder flexion, we can see muscles that are responsible grossly include the pec major initially, anterior delt, middle delt, long head of biceps, coracobrachialis. All those muscles are responsible for shoulder flexion. We can take a look at a couple of different views, and we can start to see the relationship of the humeral head as it moves in that sagittal plane direction, like you would to throw the bowling ball down the alley. Okay, so that gives us kind of a good view of the orientation and the application of sagittal plane flexion. So looking just in the opposite direction, which would be our glenohumeral extension, we can see posterior delt, middle delt, long head of the triceps, teres major, latissimus dorsi, all acting to extend the elbow, extend the shoulder in the sagittal plane. So we can start to see that motion that occurs in that direction. And we get about 60 degrees of extension at the glenohumeral joint when we lock the scapula. We're going to come back and visit that glenohumeral and scapulothoracic rhythm when we talk a little bit more about the scapula next time. So we can see that extension coming back. So that's going to be the direction that we would need to go. And there's a nice view highlighting the latissimus dorsi as it wraps around the ribs. But I think what is important for us to look, and if we use our throwing the bowling ball as our example, this is the direction that we have to move the arm to load those anterior flexor muscles. So we can see that pec getting stretched. We can see the anterior delt getting stretched. We're proprioceptively loading those muscles in preparation for that flexion motion. So this gives us that ability to to load and explode for normal functional activities to occur. So our sagittal plane motion is that flexion extension. Our frontal plane motion then is really that combination between the deltoid and the supraspinatus. And this is where we get all three heads of the deltoid working simultaneously to get that frontal plane motion coming straight out, and the supraspinatus working to initiate and help to guide that motion. So we can see that motion occurring through the frontal plane. And this is a good example of and let's kind of remember this picture in our head here of the humerus as it glides against the glenoid fossa during that abduction. So when I look at humeral adduction, it's really the motion that's returning the humerus in the frontal plane back to its resting position, because the chest wall gets in the way. But when I actively pull down, so when I'm pulling a resistance band back across, we can see that the muscles responsible for that are the infraspinatus and teres minor, but really primarily the subscapularis, really what's responsible is the teres major, the latissimus dorsi, and we can start to see that pec major as it relates to pulling the humerus back into that adducted position. So this is actually a pretty good view of a force couple that needs to occur in a reverse action between the latissimus and the pec when I am ambulating with crutches. So these muscles will work in a reverse action to lift the trunk with crutch walking. Important component to recognize that I have to have enough pec and enough lat strength to ambulate normally with crutches. So if I have somebody that doesn't have this upper extremity strength, I can't put them on crutches. I have to use an alternative form of ambulatory aid for them to walk safely. So now when I look at horizontal abduction, which is a transverse plane motion, we can see that humerus being pulled posterior, and that typical range of motion is about 45 degrees. And we can see the muscles responsible. I've faded the deltoid. We get some lats functioning. We get some rotator cuff, infraspinatus teres minor functioning, and we'll get a little bit of a superior aspect of the pec. But it's really, again, think about load and explode. We're loading these anterior chest muscles in preparation for the ability to bring it back across our body. And that direction of bringing it back across our body is that horizontal adduction. So when I look at horizontal adduction, we can see this anterior roll, and we can see the direction that the humeral head has to glide. So again, a transverse plane motion, horizontal adduction, bringing the arm across your body. We can see that pec shortening. You can see the lats pulling it, helping to pull across in that position. Anterior delt working to pull across. See a little bit of the coracobrachialis as it assists in that motion. And then looking through the chest. So neutral position, external rotation. We can see that the position of the traps are shown as scap stabilizers, and again, we're going to visit that in a more thorough explanation when we talk about the scapula. But primarily, external rotation is occurring with the infraspinatus and the teres minor. So let's take a little bit closer look at how that motion is occurring, especially as I fade the deltoid, and we can see that attachment and that those rotator cuff muscles pulling the humeral head in that lateral rotation. And we can see that lateral spin. So we need to be able to identify that glide that's occurring. Again, remembering our rule of a convex surface moving on a fixed concave. So think about what those mechanics, those joint rule mechanics are going to be, and we'll visit that here in a second. And then we can finish up with glenohumeral internal rotation. Glenohumeral internal rotation is a function of motion with the lats, the teres major, the pec, again pulling that humerus into internal rotation. So we can see that humeral head rolling medially, and then having that ability to again identify what the accessory motion is. So let's talk a little bit about the accessory motions that are apparent in the glenohumeral joint. Let's take a minute and talk a little bit about accessory motion within the glenohumeral joint, which really is a function of the concave fixed surface with the moving convex. So when I have a diagram of a glenoid fossa, posterior, anterior, and my diamond here at the resting position of the humeral head contact within the fossa. So when I move into abduction and the arm comes up in that frontal plane, up over the head, out to the side and over the head, the accessory motion that has to occur is a downward glide. So that's going to be the position of contact within the glenohumeral joint during an abducted arm, with an abducted arm. When I come back and look at external rotation, I'm going to move anterior. So I get anterior glide with internal rotation, and I get posterior glide with internal rotation. So if I go internal rotation and elevation, so this is a direction that I'm going to go with flexion, then I'm going to have that external, or that posterior glide with a inferior glide to get my arm up and over my head. With external rotation and elevation, I'm going to start to get more of that anterior inferior glide. So we can start to get an idea of what has to happen with normal mechanics and what motions may be restricted if I have tightness in any part of the capsule. So if I have a tightness in the posterior capsule and I start to lose my internal rotation motion, that may have a direct impact on the ability, for me to get my arm up over my head in flexion. If I can't get here, because I know internal rotation and flexion go together, if I can't get my arm, my humeral head here, I'm going to be limited, or I'm going to create a scapular dyskinesis. Same thing if I have tightness, or if I have excessive motion and I don't control the direction of the humeral head during external rotation, I may slide around, that humeral head may slide around, and I may end up with the humeral head bumping superiorly in external rotation, which would then impinge the biceps tendon, or may even impinge the supraspinatus. It may impinge the subdeltoid bursa. So I start to see how abnormal joint mechanics can have a direct impact on both stability and function and mobility during function. So when I look at dynamic stability then, again, the dynamic stability is really a function of the force vectors that are created by the rotator cuff. So I have a downward pull with the infraspinatus. I have a downward medial pull from the subscapularis, and I have a downward medial pull from the teres minor. So those three create, when I look at resultant vectors, I have a medial vector that will stabilize and an inferior vector that will help position the humeral head inferiorly, again looking back at our mechanics, during elevation. So now I have the force of the deltoid pulling up into an abducted position, which will then also cause a superior glide to occur in the humeral head. So that superior glide is countered by the inferior pull of the infraspinatus, the subscapularis, and the teres minor. So that's a good look on what we need to examine with glenohumeral joint stability, glenohumeral joint mechanics, and glenohumeral joint function. Next time we'll take a look at the scapulothoracic joint and its contribution to normal mechanics and normal function, and as we start to put the links together between glenohumeral function, scapulothoracic function, and upper limb function.